In today's session, we have two brilliant scholars, titans, I would like to call them, reigning over several domains, who will engage in a conversation that promises to answer questions we all have related to illness and the suffering it brings, of strength, both physical and mental, that is needed to navigate through these difficult and dark alleys, of hope and healing, different literature and art forms promise to bring us. Dr. Azra Raza, as we all know, is a cancer specialist, professor of medicine and clinical director of the myelodysplastic syndrome, I hope I've pronounced it correctly, center at Columbia University. Dr. Raza has published extensively in top-tier journals and authored the critically acclaimed book that you all have the good fortune of getting signed by her, The First Cell and the Human Cost of Pursuing Cancer to the Last. Accepted and admired, and reviewed as, and I quote, no ordinary book of medicine, but a book of wisdom and grace by an author who has devoted her life to making the unbearable easier to bear. End quote. The range of her scholarly pursuits is evident from another publication she co-authored, Ghalib Epistemologies of Elegance, showing her literary engagement with Urdu poetry. And I must stop here and thank Babar Saab for making Dr. Raza's presence among us possible. She will be in conversation with Professor Basit Kaushal, our very own professor, who has not one but two PhDs. So I like to call him Dr. One from Drew University in the sociology of religion, and the second from the University of Virginia in theology, ethics, and culture. He has the honor of being the first faculty member of the Department of Humanities and Social Sciences at LUMS to be promoted to full professor in 2018. His research areas span the area of religious studies, philosophy of science, and sociology of culture. He is especially interested in nurturing a conversation between the falsafa-e-khudi of Allama Iqbal, the pragmatism of Charles Peirce, and the social science methodology of Max Weber. Before we go to Professor Azra Raza and Professor Basit Kaushal, please allow me to invite Professor Muhammad Sabih Anwar, another pioneer of the Two Cultures Initiative. So he introduces this forum in some more detail. Professor Sabih is a professor of physics who has served as the Ahmad Daud Chair and former Dean of the LUMS Syed Babar Ali School of Science and Engineering, and his research interests beyond quantum physics that he specializes in include the culture of science in the Muslim world and science education in developing economies. As part of the Khwarizmi Science Society, he leads one of the region's biggest science festivals called Lahore Science Mela, which combines scientific and cultural capitals in an inviting show for thousands of visitors. With that, Professor Sabih Anwar.
बिस्मिल्लाहिर्रहमानिर्रहीम। शुक्रिया डॉक्टर नदरा। आपको जो इस वक्त तस्वीर नज़र आ रही है, इसमें दो शख्सियतें सामने। एक शख्सियत इनमें से उनकी तस्वीर फर्जी है मेरे ख्याल में, लेकिन जो तस्वीर फर्जी नहीं है, जो असली है, क्या आप में से कोई पहचान सकता है वो कौन है? चलें, जो फर्जी तस्वीर है वो मौलाना रूमी की है। जाहिर है हमारे पास मौलाना रूमी की कोई असली तस्वीर शाज ही मौजूद हो, इसलिए ये एक मुसव्विर का वहम है या गुमान है कि रूमी ऐसे होंगे। लेकिन जो दूसरी तस्वीर है वो एक मशहूर रियाजीदान की है, جو فلسفی بھی تھا. کیا آپ پہچان سکتے ہیں؟ یہ ہے گوڈ ایلف. تو دراصل یہ تصویر ٹو کلچرز انیشیٹو کا ایک خلاصہ ہے. ٹو کلچرز انیشیٹو جب باسط کوشل صاحب نے پچھلے سال قائم کیا, ہمیں شرف حاصل ہوا کہ اسکول آف سائنس اینڈ انجینئرنگ میں اس کی میزبانی کریں اس انیشیٹو کی. بنیادی مقصد یہ تھا کہ جو سائنس اور ادبیات, سائنس اور فلسفہ, سائنس اور کلچر, اس کے درمیان جو بڑی ایک خلیج قائم ہے اس کو کیسے پر کیا جائے. جو ایک خیالی, جو ایک فکری بود موجود ہے, اس بود کو کیسے قریب لایا جا سکتا. میں فزسسٹ ہوں, میں جب کلاس روم میں جاتا ہوں میں کوانٹم فزکس پڑھاتا ہوں, بڑی دقیق مثالیں, ریاضی کی مثالیں ہیں. ایک کوئی لگتا ہے کہ کوئی ادب زبان لکھی جا رہی ہے تختہ سیاہ پہ, اور اس کو سمجھنا بہت مشکل ہوتا ہے. لیکن جب میں کلاس کے آخر میں سوال پوچھتے ہیں اسٹوڈنٹس مجھ سے, تو مجھ سے صرف فزکس کے سوال نہیں پوچھتے, مجھ سے پوچھتے ہیں آخر ایسا کیوں ہوا. کیا اس سارے جو آپ ہمیں بخارات کی دنیا اور ممکنات کی دنیا دکھا رہے ہیں, کیا اسے ہم اپنے نفس کو پہچان سکتے ہیں؟ کیا اس سے ماورائے فطرت ہمارے جو احساسات ہیں, جو خیالات ہیں, جو ایموشنز ہیں, کیا ہم ان کی دنیا تک پہنچ سکتے ہیں؟ اس کا معاشرے میں کیا اثر ہوگا؟ اس سائنس کا معاشرے سے کیا تعلق ہے؟ انسانی آزادی سے کیا تعلق ہے؟ انسانی نفس سے کیا تعلق ہے؟ تو یہی مقصد تھا ٹو کلچرز انیشیٹو کو قائم کرنے کا, کہ یہ جو ایک دوری پیدا ہو چکی ہے سائنس میں ملکوت کے علم میں, یعنی جو چیز ظاہر آپ کی آنکھوں کے سامنے ہے اور جو پوشیدہ ہے, اس کے درمیان جو ایک تفاوت ہے اس کو کیسے دور کیا جائے. تو پچھلے ایک سال سے مختلف طرح کی محافل کا اہتمام کیا جا چکا ہے ٹو کلچرز انیشیٹو کے فورم پر. یہ مکالمے بھی ہیں, یہ بحثیں بھی ہیں, اس میں شعر و شاعری بھی ہے. اس میں اگر میں آپ کو پچھلے سیمیسٹر کی جھلک ہے مختلف تقریبات کی, تو اگر آپ دیکھیں پچھلے سیمیسٹر میں جو موضوعات تھے ان کا تعلق خود آگہی سے تھا, خود شناسی سے تھا. آپ جانتے ہیں کہ خود آگہی کتنی اہم چیز ہے, اپنے نفس کو دیکھنا, معاشرے میں, کائنات میں اپنے مقام کو پہچاننا. یہ ایک ایسی خود آگہی ایسی چیز ہے جس کے بارے میں اقبال کہتے ہیں کہ خودآگاہاں عظیم کے خاکداں بنوں جسد, کہ آپ ایک خاکدان سے باہر نکل کے ایک عالم بالا کی سیر کر سکتے ہیں اگر آپ خود ہی کو پہچان لیں. تو دا کامنل سیلف پر ایک مکالمہ تھا. پھر ہمارے باسط صاحب نے دا ماڈرن سیلف پر ایک نہایت خوبصورت 2 لیکچرز کا اہتمام کیا, سائیکولوجیکل سیلف. پھر MIT کے پروفیسر جیمز ویسٹ کوٹ نے باڈی, واٹر اور گورننس پر ایک تقریب کا اہتمام کیا. اور دا سائنس نیڈ فلاسفی, یہ سائنس اور فلاسفی کا جو سنگم ہے اس پہ بات ہوئی. اور پھر محمود شبستری کی جو کتاب ہے گلشن راز, اور علامہ اقبال نے جو اس پہ تضمین کی گلشن راز جدید, اس پر ایک بڑا خوبصورت مکالمہ ہوا. تو یہ ٹو کلچرز انیشیٹو کے پچھلے سال کے کاموں کی کچھ ایک مختصر سی جھلک ہے. آج کی تقریب ظاہر ہے ایک نہایت خوبصورت باوقار تقریب ہے. ہماری آج کی خاص مہمان ایک عالمی شہرت یافتہ ایک سائنسدان بھی ہیں, لیکن اس سائنس کو ادب کے ساتھ, نفس شناسی کے ساتھ, آفاق شناسی کے ساتھ جاننے کا گر بھی جانتی ہیں. تو اب مزید کچھ کہے بغیر آپ سب کا ایک بار پھر بہت شکریہ, اور امید ہے آپ آج کی محفل سے خوب سوز بھی اٹھائیں گے اور لطف بھی اٹھائیں گے.
Professor Azra, Raza, can I please request you to be Dr. Basit Kaushal, please?
Okay, Asaba, I will begin here. Edmund Pellegrino, he has said, medicine is the most humane of sciences, the most empiric of arts, and the most scientific of humanities. And it just beautifully captures what it means to be a doctor, to be a practicing doctor, whose quote unquote object of inquiry is a living, breathing human being who has developed an illness. And this is the way Pellegrino describes medicine. And if you could, from your book, maybe an example of the how is it that medicine is the most humane of sciences from your personal experience from the book? That what is it that makes medicine a humane science or demands that the medical practitioner be a humane person?
Adab, and thanks to all the people who have been coming over and over to hear my 2 talks a day. It's such an honor and a pleasure to be in London. It's my first visit here ever. And it's been a fantastic eye-opener for me to see so many incredibly talented and exceptionally well-trained people, but who are original thinkers, who are really charting new courses here. This whole idea of the Two Cultures Initiative is um, such a timely thing for us because we seem to be losing that trend. And I congratulate all of you, and I am particularly honored to mingle and to have a chance to interact with the students of London. Professor Busteni, who's my colleague at Columbia University and well-known professor and well-acknowledged scientist, cancer researcher. She has also had the best experience with students and faculty, of course. So on behalf of both of us, we'd like to extend our gratitude for this invitation and look forward to coming again. Your question is a very good one, of course, about the importance of empathy and how medicine is a humane science. It's in fact the most social of sciences. If you think about it, as a new patient comes to see us, startlingly, within minutes, they begin telling us the most intimate details about themselves. And it's a humbling experience because what you realize is that disease has had some form of a disorienting effect on the individual. And as they're trying to recount their story, it's quite fragmented. Their stories change from week to week and then from mouth to mouth because the patient will say one thing, but the family will deny and say something else. And symptoms change from signs back to symptoms. And what you realize is that there's such a great responsibility for the physician to read between the lines, to be able to make sense of a story and then recount it in the chart of the patient in such a way that the next person who's going to read it will be able to get the gist of it. And I always feel somehow anxious about this narrative aspect of medicine and understanding the social components that are surrounding the disease process, which makes this intermingling of a very clinical interaction along with a very social interaction, where one has to seamlessly chart a course not just for yourself, but for future generations who are going to be reading that chart. And so I always say to my students at Columbia that in order to even get the patient story, you need to hear more hearingly. You have to, like the blind, develop an extra power of hearing. It's not just the words that the patient is saying, but the body language, the expression. And so I think read the anxiety that is coming across. And to me, the social interaction part is very much dependent on how you are reading the patient and what is their need and how are you going to offer the best possible support for that particular need, which differs from patient to patient and the family, because especially the kind of disease I'm dealing with, cancer, affects an individual, but the ramifications are on the whole family, in fact, on the community, essentially. And so the interconnectedness of the disease, the violations of the psychic energies, all these things have to be taken into account and then narrated properly and reacted to properly. So it's a very complex system that has to be navigated.
As you're speaking, it just occurred to me, so this is not just an interaction between the doctor and the patient. First of all, you have to have a special skill, right? To read between the lines, as you said. But you also mentioned something about the chart, that you have to then put your observations down in black and white, knowing that that chart will go into the hands of one of your colleagues, and that they will also, that how important that it is, you're not only in conversation with the patient, you're also in conversation with your colleague who will follow later on in another department. And I guess that means maybe where quote unquote the scientific part comes in, that that black and white in which you have whatever you have read between the lines. Now it has to be translated into some black and white, someone who has not seen the lines yet, but they will see them later. So you have to put it in that language. So that's a very different skill that is needed, without which one cannot be a good doctor. Is that an accurate?
Very accurate. In fact, when you ask me, it's a social science. I don't want to limit it to some sympathetic, empathy, compassion interaction, because there's so much more to it than just that exchange. By the way, has anyone seen The Crown, that series? Okay. So in The Crown, they show the life story of Queen Elizabeth, and she knew that she's going to be the next queen when she was 13 years old. And from that moment on, her training was that she is above average. She is divinity. She must not interact with common people. So she had to maintain a distance from everyone. But on the other hand, there was some kind of an avalanche and 60 children died, and she was expected to go and show her sympathy. And then she didn't go because she was so scared because she felt like she might break down and she can't afford to because she's supposed to maintain her distance. And she didn't go. And immediately the public got very angry and they started dissing her, so she had to go. And she didn't break down. It's that seeing that episode, Basil, reminded me very much of the fact that as doctors, what we are trained to do is not to allow our emotions to become involved with the patient because emotions cloud judgments. That's the understanding of science. And judgment is clouded because of emotions. You can't make the right decisions for the patients. That's what we are told to do. Don't let your emotions get in the way. But what does the patient expect? Patient expects empathy from you, sympathy from you, understanding from you, a show of emotion from you. And I feel like that same dichotomy exists a lot because it's supposed to be the most social interaction in a way. And yet you are trained not to be that social. And I don't understand this kind of an internal contradiction within the training process of medicine.
So in order to be a good doctor, you have to have an artistic sense, an aesthetic sense. You have to have a scientific sense, an empiric sense, and you have to have a social sense and the humane sense. If these three things do not come together, you cannot be a good doctor. And Dr. Saab, you're a very good doctor. You're like, and yeah, obviously we're not saying this because you were among us. There's a 40-year track record of this. That how in order to be a good doctor, these three elements, which are maybe worlds apart, they're integrated in one person. And as going through the book, it looks like it's a lament that how these three elements have become separated, separated from each other. And then a good part of the book is the consequences of this separation. And the first thing is you've already alluded to it, that in your training as a doctor, when a patient comes in, that is not a unique individual that is walking into your office. That is not the priority for the doctor. The doctor's priority is that there's a set of protocols, a set of guidelines that will determine a priori how the doctor is supposed to interact with this unique individual. So irrespective of the uniqueness of the individual that comes in, the guidelines are quote unquote universal. So we have this thing where the universal guidelines take precedence over the uniqueness of the case that is in front. So with your permission, right, I would like to quote from your book, that that points to this characteristic of now how medicine is actually practiced or actually taught. Before how it is practiced, how it is taught. The medical student, before they ever see a patient, they have already been trained that this is how you will deal with the patient. And you say, experts have devised formal criteria for best practices, and any nonconformity could leave the deviant open to legal challenges. While evidence-based medicine is essential, it is not sufficient by itself when caring for individual patients. This is now what I would like to ask is, are universal treatment guidelines sufficient for providing effective care? Why or why not? And how might they fail to address, or how have they failed to address the nuances in individual, in your experience?
I think simply stated, when guidelines of any sorts are made, the guidelines have to depend on solid data. But what are the data that we are looking at? If 100 patients had this particular form of disease or this particular symptoms, and we gave them this drug, then 20 will have a good response, 80 will not. So we can say to the patient, 80% chance is not good, 20% chance you will respond. But then the patient asks me, okay, which part am I on? Am I 20% or 80%? We don't know. So you see, you have the guideline, but then how do you apply it to the individual? A patient comes to see me, I give them the diagnosis of pre-leukemia. Let's say some 60-year-old comes and has low blood counts, and I do a bone marrow and I diagnose that they have pre-leukemia, and at some point they could develop leukemia. The very common question is, okay, you're giving me a diagnosis, so doc, what does that mean? Should I be completing my bucket list right away? Or can I plan to attend my grandson's graduation 3 years down the line? What is it you're telling me? And I have to say, I don't know.
How does that feel? How does that feel when you say you don't know and you see the look on the face of the patient? Because if if they can't get a kind of a quote unquote answer from you,
Well, that's the issue. That this is a discussion between you and me. But if there is a patient across from me, then Emily Dickinson's words are the best. Tell all the truth, but tell it slants. You have to be, and that's why the first part of the question was so important, that it is a social science also. That you need to understand what the patient will be able to absorb properly. Because you see, the patient is, I can tell them 10 things, but they will register only the 2 or 3 things that they find are giving them a positive signal. They will put everything out of their mind that is not um, fitting into a predetermined cognitive bias that they have come in with. So one has to venture into unknown territory, but gently. And the way to say it to the patient for me would be that, look, it's a good question that should you be preparing to die right away or can you plan for things? I always say that for me, I'm prepared to die tomorrow, but I live as if I'm going to last many years. And you should change that policy for disease because disease itself is unpredictable. And anyone who tells you they can predict a precise time of your death is lying or deluding you. Because again, we can say that 40% chances are you will do this, 37% chances are you will do that. Nothing is fixed. And therefore, a patient's individual natural history of the disease is far more important than any presenting symptom.
But in the way that the future doctors are being trained, how important in their training, how much emphasis or how much importance is the individuality of the patient, how much of that is a part of their training slash education? The way you have charted that space, right, between the protocols and the standards on one hand that have to be followed, but obviously there's a judgment call whether you're in the 20% or the 80%. Now, there are no guidelines, I guess, right, that will help the doctor determine that this particular patient is in the 20 or the 80%. Now, what does a young doctor or an aspiring doctor, how is it that they learn, where would they learn the importance of that? The role that they will play, the role that they will play in filling this.
You know, there are lots of doctors in my family. My immediate siblings, 4 of us are doctors, everyone married doctors, and then lots of children have become doctors. And one of my nieces, who's an oncologist in Providence. So, a thing about AI is going around in my family on text right now. And my niece, who is an oncologist in Providence, just this morning sent a text saying, well, I used to work at Brown University. She was there for several years, and now she's moved into a private practice. And she said, in this private practice, you know what happens? I go into a room and I'm seeing the patient for the first time or the 10th time, doesn't matter. I'm talking to the patient, interviewing the patient, asking them their family history, social history, past history, their symptoms, their signs, etc. And then I don't touch any computer, nothing. I come out and AI has been listening to the conversation and constructed a beautiful narrative for me. based on that conversation, the entire story is printed out as she walks out of that room. And all she has to do is scan it and maybe one or two corrections, and that's it. That is the chart these days. That AI is actually listening to the conversation and making these. And it's a wonderful thing because otherwise most of our time is spent on the computer trying to write up these stories. But if somebody else, while we are talking, is able to summarize it, then all the time that I have, I can spend holding the patient's hand and actually being social with them because I don't have to do that stupid scut work. So to me, it's a very interesting sort of new path that medicine is going into, which is a very positive sign, in my opinion. And by the way, anyone who goes into medicine to begin with has some reason to go into this field. And 90% of the time, at least, it is not because of money or power or fame. It is because they do want to help patients. So, to begin with, the kind of people who are going into medicine have a certain um, constitution. And styles are, of course, different for people. But the basic motivation is the same to help the individual. Now, some people, some doctors think that if they treat the patient and cure the patient, that should be enough. Others think that the psychic violation and healing is very important as the cure. And so, for medicine, I mean, the whole idea is it's as much about the body as about the soul. And so, how aware are different doctors and what is their style of taking these two body and soul parts together and combining the healing and cure part together as a result. I think it's only, I have been with tons of colleagues over the last 4 decades in the US. Vasu, I have yet to meet an oncologist who didn't want to do the best for the patient. I haven't met them, there must be some. But a lot of time my patients will complain and say, oh, that one was so cold to me. And it's just the style, but it's not because the doctor didn't want to do it. So I have to defend our profession a little bit and say that it's not as starkly indifferent as people outside think doctors are. We are human, we are moved by suffering. It's a horrible thing to see other people suffering so much. And with age and with time, it's not as if you become immune to it. It's not as if you start accepting it and doesn't do anything to you. No. Because with time and age, in fact, it has a deeper effect on you. Because now you've learned to appreciate all the other meta effects that it has on the family and the community, etc. So I think that these are very complicated issues. And for young doctors and people wanting to be doctors, my advice always is the first thing is to listen to the patient. But the second is that you will be working with many different doctors, many different specialties. Observe everyone's style of handling or dealing with the patient, but then develop your own by imbibing the best from many. And even that is not enough because you can't have a simple algorithm that you apply to every patient. Then you need to see which kind of doctor you need to be today with this patient and today with that patient, which part of you has to be there. So I think it's such that's where the individualization of precision medicine comes in. That you have to treat the person as an individual and yet take the benefit of all your experience and observations to bring it to all your faculties to bear to help that individual.
Well, this is so in order to treat an individual patient, if I heard you properly, the doctor himself or herself also have to sharpen their own individuality. And one of the ways to sharpen their own individuality is to be open to and listening to and learning from other colleagues, especially other colleagues from other specialties. That when they do this, when they're open to these other voices from other specialties and other colleagues, they themselves become they sharpen their individuality, and then they will be able to deal with individual cases following the guidelines, but dealing with individual patients as individuals. That's one way. Well, the second part of one of the second another point, right, where that integration between the artistic, the humanistic, and the empiric breaks down. One of the points is what you call the slash, poison, and burn period. The first part of the individual and the universal is I guess at the level of diagnosis. Here we're talking about treatment and how sticking with the established practice has really limited the way that they are the patients are treated. Again, these are your words. With minor variations, a protocol of surgery, chemotherapy, and radiation, the slash poison burn approach to treating cancer remains unchanged. It is an embarrassment. Equally embarrassing is the arrogant denial of that embarrassment. So, no doubt, the doctor as an individual is precisely as you described the doctor. They really deeply care about the patient that's there. But it looks like some borders have been put or defined that the patient has to be treated this way, and we described it as slash, poison, and burn. Now there is enough evidence that that we have reached maybe a point of diminishing returns, or this is not. So, can you elaborate on this, what you call the slash, poison, burn approach to cancer treatment, and how effective is it in providing long-term relief to patients?
My closest colleague at Columbia University, is Dr. Siddhartha Mukherjee. And Sid wrote the book Emperor of All Maladies, a biography of cancer. And he got the Pulitzer Prize for this book. It is being voted as one of the best 100 books ever written in fiction, non-fiction, anything. And it is a stunning history of cancer, but written so beautifully. I urge all of you to read this book. One of the things Sid did is that he took the story of the Persian queen, Princess Atossa. This is a Persian. She was the daughter of Cyrus and the wife of Darius. Atossa, one fine day, feels a lump in her breast. The first thing she did is she tries to hide it. She covers it with sheets and clothing, and she's trying to hide, but the tumor keeps growing and growing. So, first of all, the stigma associated with cancer, especially with breast cancer, you're not supposed to mention it. Even until 1950s in the US, you couldn't say the word in newspapers. Such a stigma was attached to this. So what she did is she first tried to hide it, and when it became quite prominent and started to fungate, she asked her slave to simply cut it. He took out his sword and he cut it off. She survives that surgery. And then she lived for many years. She was cured. That is the first case of known mastectomy, actually. But Sid did something clever. He uses this story and looks at if Atossa was born 100 years later, what the treatment would be, and 100 years later, what the treatment would be, and brings it to the present day. And he says from that point to today, we are doing very aseptic radical mastectomies. We take a piece of the tumor, we test for expression of hormone receptors on it, estrogen, progesterone receptors, then we look at the tumor tissue, we oncotype it, we look for the genes that are mutated, overexpressed, underexpressed. We decide whether the patient, based on this genetic markers, needs or hormonal markers. Do they need hormone therapy? Do they need chemotherapy? I mean, very sophisticated way of integrating molecular biology, genetics, pharmacology, radiation therapy, chemotherapy, everything. So he brings it beautifully. We share a lab, Sid and I, and we do a lot of our work together. Besides that, we hang out socially a lot together. So I attacked him. And I said, you are acting as if Atosa's fate is much better today. But for me, we were slashing the breasts of women 2,500 years ago. We are still doing the same. So he said, Azra, you should write a book called The Emperor Has No Clothes. I said, yes, it is the problem that we haven't progressed the way we should have. And why isn't anyone looking at that? Why are we satisfied with that brutal Paleolithic caveman approach? I can't stand it. You know what's chemotherapy like? Maybe some people in this room might have experienced it. Chemotherapy is like taking a baseball bat and hitting a dog with it to get rid of its fleas. It's a violation. It's a horrible treatment. Yes, we are curing a lot of people with these treatments, but we can do better. We shouldn't have to do this. So, to answer your question, my critique is that the definition of winning has to change. Winning the war is not we are curing 60% patients diagnosed with cancer. My question is, you're curing with what? Slash, poison, burn. That's no winning. And the same way, Basit, my criticism of the winning culture of the West. What is the winning culture of the West? You know, everything is individualism, consumerism, productivity, the attention and the focus is on positive things, positive thinking, And that does not take into account things like death, because death is non productive. Death is not helpful. So they have even medicalized death in the form that now people die in hospitals, not at home. They die in hospitals in the middle of the night, surrounded by machines. Not even nurses are there most of the time. And so that shared experience, the communal grief and experience and seeing death as a part of life has completely been removed from our lives. And it's as if denying death is going to keep the angel of death away. I had a billionaire patient the other day who came in, and when I gently disclosed to him that what we have to offer treatment, he literally got up and kicked the wall and said, "What do you mean you don't have a cure for me? I have all the money I can give you." You see, because that kind of a winning thing where acceptance of even talk about mortality is completely rejected, because what is valued is youth and vigor and vitality, and the elderly and the diseased are marginalized in a society that is concentrated on winning. And my objection to this is that these are good things. Yes, concentrate on winning, but for God's sake, change the definition of winning. The winning should not be curing cancer with slash, poison, burn. The same way the winning is not to deny death, but to accept it and make it part of your life. You know what, Emily Dickinson, how beautifully she phrases it. Because I could not stop for death, he kindly stopped for me. She treats death as if it's a gentleman escort who has come to take her out on a date. Because I could not stop for death, he kindly stopped for me. The carriage held but just ourselves and immortality. We slowly moved, he knew no haste, and I had put away my labor and my leisure too for his civility. You know, I went through all this because cancer entered my own home. And my husband got the very disease he had dedicated his life to cure since he's 15. And even I didn't realize how painful a disease cancer is until I shared a bed with a cancer patient. And here's someone who's been seeing patients with cancer for over 20 years already. But yet that experience was so disorienting for me. The other thing is, for the next 5 years, everything I thought about, because our daughter was only 4. And so now imagine trying to navigate my way between trying to get babysitters to look after my child, or rushing my husband to the hospital, or bringing and giving him chemotherapy at home. I mean, every little decision, even if it is about to go out for 10 minutes, is directed by how what's going on with him. And then he suddenly dies after practically 5 years. And I can't tell you the disorientation that came with the sudden death, because now I had nothing to concentrate, to orient myself on. That whole thing, which was the driving force, the adrenaline that was making me not even think about anything, but just keep reacting and doing what I had to do. If that gets taken away suddenly, I'm so disoriented, Pastor. I could not listen to music, I could not concentrate on my work, my poor child was suffering. But it was like I was in a haze, in a dream. And then you know how I reoriented slowly. 2 years went by and I was still listless and lost. And then I realized that the thing that brings me solace is reading, especially reading fiction, the great works of fiction. Because fiction allows you to stand in the shoes of someone else, experience what they are experiencing. And fiction, more importantly than that, you know, when a character is introduced in a book of fiction, we have reactions to it. You like this one, you hate this one, you want to kill this one, etc. And then you wonder why. So, in fact, fiction is the best way to get insights into yourself. Not just empathy for others, but insight for yourself comes from fiction. And for me, reading poetry. So you know what I did? Over the next 2.5 years, I read the 100 greatest books of the Western literary tradition. About 50 of them I already read, starting with Aeschylus and Euripides and Sophocles, and working my way all the way to Thackeray and Dickens, and then to Naipaul and the kind writers. And nothing brought more solace and more peace to my mind than reading the great works of fiction, reading the great works of art. And let me just recite one more thing by Emily Dickinson. The way I felt at the time before this problem, before I started reading, I felt a cleavage in my mind as if my brain was split. I felt a cleavage in my mind as if my brain was split. I tried to match it scene by scene but could not make them fit. The thought behind I strove to join unto the thought before, but sequence raveled out of reach like balls upon the floor. That was my state of psychic disorientation which took literally 2.5 years of a lot of other things, but the fundamental basic thing for me was reading about the experiences of others, reading the grand visions of the greatest authors, and reading our own poetry. And I think that allowed me to somehow develop solidarity, a sense of belonging once again.
Dr. Saiba, as you were speaking, and I hope I heard you right, and if I heard you right, I'm going to go back to Pellegrino's quote that we began with. Medicine is the most humane of sciences, the most empirical of arts, and the most scientific of humanities. Now, when I read this, and up till now, until about 3 minutes ago, I was reading this quote from the perspective of a doctor, from the perspective of a medical practitioner. But if I heard you right, the last 3 to 4 minutes, you were not speaking as a medical practitioner, you were speaking as a patient or someone in the close proximity of a patient.
No, what I call it is I was speaking as a cancer widow.
Cancer. Now, as a cancer widow, as someone who is witnessing this, so in order to deal with disease, we have to deal with disease as its victims, not as its not as the ones who are treating it, but as its victims. The scientific, the empiric, and the scientific, the empiric, and the humane or the artistic have to come together.
Yeah.
The way you describe that, how your study of the 100 great books, the key role that they played in helping you come together in a way, not as a doctor, but as a cancer.
Yes.
So this applies to both the patient and the doctor. The patient also has to be, or the victims also have to be. Now, with the passage of time, we know, and coming back to the book, how the three domains, the scientific, the humane, and the artistic, have been pulled apart. So this has not only impacted the relationship between the doctor and the patient, it has also impacted the way the researchers carry out their research on this disease. And you have used the phrase the mouse model to describe this. And the mouse model in cancer research, again, these are your words. This is at the research stage of cancer. Animal models used by scientists to study cancer are far too simplistic and artificial, utterly incapable of recapitulating a fraction of the complex disease I have seen. Mouse models are practically worthless for cancer drug development, but funding agencies and the current scientific culture are so heavily invested in the system that nothing can make them accept the folly of their failing models. Mouse models are the real elephants in the room. This is at the level of research in cancer. And you're saying that the dominant model is, you use the word failing. Can you please explain what mouse models are and their role in cancer research? How are these models impeding progress in this field?
I want to clarify that I'm not against use of mice for study of biology or cancer research at all. The only thing I'm against is you cannot take a mouse, kill its immune system completely, then take cells from a patient's tumor, put them in this mouse, they start to grow. Now, this is a very different environment in which they are growing than the human body. The immune system has been killed, and this is a mouse, not a human. And then you are going to treat it with whatever new drug you have developed and the treatment works and the mouse is cured and you declare victory and you say, I'm curing this type of cancer, except when that drug is brought to the bedside of the patient suffering from that disease, it fails 95% of the time today, and the 5% time it's declared a success. It should have been declared a failure because all it's doing is improving the survival by a few months for 20 to 30% patients. None of these things are curative. The only cure for solid tumors really is surgery. You still have to cut it out. There are very few small lumps and things superficial which can be treated with radiation. But chemo can't treat any of the solid tumors. Chemotherapy is treating liquid tumors. And that too is a horrible treatment for them. Yes, it cures a few, but very few. So the question comes up over and over that what are we doing wrong? Well, what we are doing wrong is we are not studying humans. I'm told that we can't study humans because we can't do same kind of manipulations that we can perform in an animal model, that we can kill the animal and look at the effects of whatever we were manipulating. Yes, you can't do that, but then don't ask those questions. That's my simple answer. Look, the only good news we can give a cancer patient is don't worry, we found it early, so we can help cure you. What does that mean? Detection, early detection is good. But again, the definition of early detection right now is stage 1. But stage 1 requires slash, poison, or burn. I'm saying you need to redefine that. You need to say, no, I want to diagnose cancer at a stage where even lifestyle changes would prevent further progression of the disease, where you don't have to use these primitive therapies. What is that stage? Well, inception of cancer. We need to stop chasing down every last cell and we need to revolutionize methods of early detection. Let's not rely on mammograms and pap smears and PSAs and colonoscopies and CT of the chest occasionally to give us results. No. You know what people tell me? Well, early detection hasn't worked because you know what the statistics are? In America, we spend $27 billion a year on these 5 screening tests, which I just mentioned. $27 billion. Out of those that we test, 9 million tests come back positive. But a positive mammogram doesn't mean the person has breast cancer. Now you have to go in and biopsy. A high PSA doesn't always mean person has prostate cancer, could be from some other reason. So now, out of those 9 million that we found positive, 8.8 million turn out to be false positive. The individuals of whom you had a positive test were dying of anxiety, but then the biopsy proved that, as Woody Allen says, the 2 words that make humans happiest in this world are, it's benign. So people are so anxious until they hit. I'm telling you that for $27 billion a year, we are basically diagnosing 200,000 cancers. Because out of 9 million we found positive, 8.8 million were false positive. Is this really an efficient way of spending money? But that's the criticism people say. Well, you see, we have been using these early detection tests and still people are dying of the same rate. Well, so get better tests. And you can't get better tests by studying animals. You've got to study humans. So the question is, how do you study humans for early detection? Who do you know will get cancer? I mean, if I start following one person, they may not get cancer for 30 years. Well, there are some people who are at high risk of getting cancer. I started my career studying acute myeloid leukemia. Within a few years, very clear to me, in my lifetime, this deadly disease, so malevolent, so malignant, not going to be cured. And I was right, we are using the same two drugs we were using in 1977, we are using in 2024 to treat that deadly disease. So in 1984, I said to myself, we have to find this early, that's the only way. And it turns out there are people who have pre-leukemic conditions, and that's what I started to focus on. Pre-leukemia is what Nudra couldn't pronounce, myelodysplastic syndromes, that is pre-leukemia. I focused on these patients who just present with low blood counts. They don't have leukemia yet, but if you follow them, 30% will develop leukemia and the others will die of just worsening blood counts. So I started following these patients, and as you pointed out, I started saving samples of these patients in 1984. And today I have the largest tissue repository in the world of these diseases, 60,000 samples from thousands of patients that have been longitudinally obtained. Have not wasted them. I've been waiting for the best technology to develop to interrogate the samples in a comprehensive way. Not just do genomics, but genomics, transcriptomics, metabolomics, proteomics, multiomics, and or longitudinally to trace the disease back to inception and then use that as a test in humans to find cancer early.
Again, the humanity in all of this, for you to save the samples. Just when, how did that even occur to you? 1984, you were early stage, very early stage in your career, I guess. If you begin in 77, you were a junior doctor. How did, how did the established authorities treat you when you took, let's say, when you did the first 10, you know, and then when people find out, you know, Azra is doing this thing, how can you say something about that?
So, first of all, what happened, Basit, is because I was a stupid immigrant. And I was just not trained in that system. If I had gone to school in America, I would next move would have been to try and develop a mouse model of leukemia. That never occurred to me because I had come from Pakistan. I said, if I want to cure this disease, I better have samples to study. And we could just store samples, and then slowly more formalization and rules and regulations appeared. But that's fine. I mean, we continuously have to, in fact, I love guidelines and rules because that keeps us vigilant about everything. So we're very stickly, we're big stickler for rules. So I think it happened so naturally for me that I just was saving samples and then that kept growing bigger and bigger. And all the time I was taking them out of freezers, 200 patients at a time, 300, and publishing continuously on findings on human samples, but always saving some extra. So that today we can go back 35 years and pull samples of people who died within 6 months or who survived 10 years and compare them and say why, what was different about them.
So you did this. You could not have done this if you had stayed within the box. This is thinking outside of the box. And obviously there were other colleagues at that time and many colleagues before who could have done the same thing but never decided they never tried. So I want to not go to the
Well,
next.
that's why in the US, the other title for the first cell in my book is The Satanic Verses of Medicine.
Well, now we'll get to that. You know, what makes them really satanic because there's you know, we're all part of an institution. None of us can escape an institutional setting. And you're practicing this in institutionalized medicine. And with every institution, there's an established establishment, deeply entrenched establishment. And you describe this establishment and what it has done in terms of narrative building, and then the impact of the narrative building on not on at the level of research, at the level of treatment, and at the level of practice. What this establishment has done. Newly minted key opinion leaders, with the blessing of their scientific mentors, inherit the exclusive power to define rules, monopolize grant funding powers, and reward each other with perks the field has to offer. Adding a final insult to injury, these little arrogant cliques manage to hijack the entire narrative in a field. Young researchers and all oncologists must think differently, to question dogma, to reject the deep-rooted archaic traditions, to discard the existing inadequate research models in order to solve the cancer problem. End of. These are your words. My question: can you elaborate how how the narrative in scientific domains and universities is hijacked? And if this continues to happen, if this does not change, what are the implications for the future of medical field and other disciplines?
Yeah. Well, you left out my favorite sentence about this,
I'm sorry.
which is that I say something like recently a young oncology researcher from another institution came and delivered a lecture at Columbia University. His ego was so dense that light was bending around him. They are so full of themselves. Oh, Dr. Raza, you belong to the old school. They come in riding on their white stallions and they're going to go and deal with this issue of cancer with their new technology and research things. And that's the kind of arrogance, that sort of denial of history, denial of the complexity of the disease itself, which creates a problem. The other problem is that in any given field, the progression is pretty similar, whether it's the arts or the sciences. You begin everything with good intentions. But then what happens is, as the field is progressing, it becomes more and more ossified rather than opening up. Why? Because there are two people who can take the risk. Either the young investigators, but their problem is if they think differently from the field, then their hypothesis, their idea could turn out to be wrong. And you can't afford to risk being wrong when you're just starting a career because your salary depends on that. So young people can't take the risk of changing from the old mold. The older individuals, the investigators who have been in the field for 20, 25, 30 years, they can't afford to change because that's the only thing they can do. So they have to perpetuate that idea. And they're the ones mentoring the young people. They're the ones sitting on all the granting agencies. You know what really shocked me the other day? It's really sad. But one of the young fellows who I have trained for many years, since he was a resident and a fellow, came to me because he interviewed at many hospitals for a full-time job. And he said that basically the question most people would ask me is, okay, as an oncologist, do you want to publish in the New England Journal of Medicine or in Nature? If you want to publish in Nature, you should work with this basic researcher. And if you want to publish in the New England Journal of Medicine, you should work with this clinician who's running clinical trials. And this gives me a headache. Because how is it possible that our very goal of life is to get a paper in Nature or New England Journal of Medicine? What about the patient? How about curing the disease? How about doing something to actually change the mold? If you are setting the goal for young people as getting huge amounts of dollars in grants or publishing in high profile journals, then I'm sorry, your sights are very low. You have no vision, in my opinion. But that has become the definition of success. How sad is that? So we started with a good idea that, hey, we want to learn about cancer. How does this work? So let's see if we can create cancer in a mouse and try to study. That was a good idea, but year after year after year, decade after decade, that hasn't helped. Everyone tell me, oh, we have developed great biologic insights, even though they haven't been translated into improved therapies. We have better biologic insights. We understand cancer better. You know what my answer is? No, you don't. Because if you did, you would improve treatment. What you understand better is whatever artificial system you have created in a mouse. Yes, you understand that better. But that's not the real cancer. I'm sorry. Because that should translate into improved therapies. Once again, I don't want people to go out thinking I'm against all animal work. No, it is very good for something. In fact, Professor Kusteni and I work together all the time in this. That yes, we have to ask certain questions about the mechanism of for example, a signaling pathway or some genetic mutation we want to look at. Mouse models are very good for that. But you can't do drug development in mouse models. You can't treat a mouse and see that it has responded and assume that now humans will respond. No. So these are complicated and separate issues. But I feel very upset about the fact that somehow our our goals have become trying to extend survival of a cancer patient by a few months. And to me, that is just an unacceptable goal completely. I'm the only oncologist, I think, and Stabula is my witness sitting here, my colleague from Colombia. I'm the only one who keeps saying that no, I want to cure cancer and I want to cure it in a compassionate, patient centric, patient friendly way. Not cure it with slash, poison, burn, but cure it by finding the first cell and preventing it from becoming the end state monstrosity that we can't handle. That is the cure that we should be seeking.
Azra, this quote describing the establishment and the hijacking of the narrative and the types of star students it is producing is that light bending egos. The light bending egos are not just among the young doctors at Columbia. It's difficult to find a discipline we do not find such egos. When I read just your introduction, just your past introduction, and I said, "Whoa, look at what she's saying."
The most important sentence, according to my editor and publisher, is on the second page, which is no one is winning the war on cancer.
In spite of incredible amount of resources and very, very loud claims and grandiose projects and winning. We're winning the war on drugs. We're winning the war on this. We're winning the war on that. And we know a number of other wars that they have not won. After having declared victory, that it has been won.
You know what? One thing I say, guys, before gossip goes on. Sorry to interrupt you. But if a cardiac surgeon is trying to give history of cardiac surgery, they will tell their medical students that show them leeches because that was the only cure for the longest time for heart disease, put leeches. Or they would show them saws that could cut bone and things like that. But if an oncologist wants to teach history of oncology to medical students, all they have to do is take the student for rounds on the inpatient service. Because nothing has changed for us. It's the slash, poison, burn.
Well, this is again how you're describing the situation in the area of cancer research and cancer treatment. My own area, one of my areas is sociology. I shared this with you. dinner, that after reading your introduction right away, a 1994 article by Peter Berger, one of the leading sociologists in the United States, passed away about 5, 6 years ago. In 1962, he wrote a small little book called Sociology and Invitation. So, as a young sociologist, he wants to encourage other graduate students to take up sociology, for doctoral work, because this field is just emerging and it holds a lot of promise. And he's very, very, very enthusiastic. And then this is 1962-63. Then in 1994, he writes an article titled Sociology, a Disinvitation with a question. And now when he is describing the conditions within the field of sociology, what you call, what here is a cut, slash, and burn. It is, over there it's ideology, it is the mathematization of the social sciences, it is aping the hard sciences. So meaning that in sociology we have the exact same problem at the macro level. Then we read some of the works done by in physics. Sabina Hosenfelder is a leading physicist. Lee Smolden is a leading physicist. They are lamenting that a similar condition exists within physics. So whether it is physics, whether it is sociology, whether it is cancer research, we have a situation where we have hit a wall, and we are not willing to recognize the fact that we have hit a wall. And without realizing that we have hit a wall, we are not even willing to be open to other alternatives. Not other alternatives that we may have to invent or find or discover, but certain alternatives, the beginnings of which are already present. And Dr. Saha, are there some alternatives of which the beginnings are already present in your field, which would help emerging institutions in the global south? That instead of doing, quote unquote, copying the best practices over there, yes, we copy some of the best practices over there, but some of those best practices we leave there because they have a track record of being shown that they are not producing the results that best practices should show. So, any suggestion for emerging institutions where there is the space is still there. The institution has not yet become crystallized or solidified, that where these alternate ways could be nurtured.
जख्म फलता है मुस्तकिल बरसों, हादसा एकदम नहीं होता. These little things have been collected, and this formula, this algorithm can apply to any field. That you need to diagnose problems early and keep fixing them, because if you don't, then you end up with the Middle East crisis or the Kashmir issue, or we are just incapable of recognizing, or we love to simply overlook and ignore and act as if it can be swept under the rug. In every field, the same issue is going on. So my advice for the future is, first of all, interdisciplinary. Exactly this two cultures kind of approach. That don't use this reductionist strategy of locking yourself in silos. Rather open up, and the interdisciplinary nature of taking contributions from different fields is very important. I think in addition to that, redefining the matrix of success is very important. The success of a culture is not this winning, but winning has to take into account human frailty, our constant feelings of loss and longing and pain and anguish. I read a book called The Leopard. It's a great novel by Giuseppe di Lampedusa. And my friend Edward Said wrote a beautiful review of it and he recommended I should read it. So, in this novel, there's a count who's lying in the Italian book, of course. He's lying on his deathbed and he's recounting the happy moments he has had in the past 73 years of his life. 7 days when he was a teenager and first fell in love, and 12 days when he did this, and all the calculations out of 73 years were 2 years and some months of peace and happiness. The rest of the time is spent in struggle, strife, anguish. And we have to take that into account. We have to understand that winning has to be accepting human disease, pain, suffering, and even death. It's all part of our life. That we need to have a broader view of things. We have to incentivize risk taking instead of shutting it down. We have to have narrative improvement. We have to be able to convey the thoughts properly in language that others understand. And I think one of the most important things for me is systems thinking. You can say that water is a liquid. It is made up of hydrogen and oxygen atoms. You freeze it, it becomes ice. It still has hydrogen and oxygen atoms. But then how do you explain the slipperiness of ice? Where did that quality come from? It's made up of the same. It's an emergent property. When phase transition happens, something new has emerged. That's ice has developed slipperiness. So you can't account for it by H2O. This is the kind of thinking we must encourage in all our young people. And we need to be able to leverage the new technology to address the current issue. We have to have a broader framework of thinking. We have to have interdisciplinary approaches. We have to redefine what success and winning should mean in any discipline. We have to have a systems biology approach and we need to use all of technology. And don't be scared to do it. For God's sake, you have to simply get up from your room, go next door to the next department and talk to someone in philosophy and talk to someone in physics, talk to someone in English literature. That's all you have to do. I think that the future is very bright, by the way. And I do think that somebody asked Oscar Wilde, how did you lose your money? He said, gradually, then all of a sudden. Well, we have been on this gradually path for a long time. But I think the inflection point is here because hundreds of thousands of the smartest researchers have been really working 14, 16 hours a day in cancer research for years and years and making small contributions that haven't shifted the paradigm yet, but we are reaching the inflection point thanks to that effort of thousands and hundreds of thousands of individuals. We have to recognize that art may be I, a Van Gogh can stand and paint the starry night, but science is we. It is an interdisciplinary approach, no matter whether it is the social sciences, the life sciences, or natural sciences. Everything is related, everything is interconnected. I think these pluralistic ideas are very important.
To sum up, this is one person, and there's this institution. This is Dr. Azra Raza by herself, and there's this deeply entrenched institution. And Moby Diani had, when she went to the United States in 1977, it's difficult for us to imagine what the situation was like in 1977. They were just coming out of actual segregation. Very few school systems were integrated voluntarily. So to be a woman, to be brown, to be Muslim, as they say in the United States, you have 3 stripes against you already. You already have 3 stripes against you. You would go there and then, accomplish what you have accomplished.
No, that's why it's taken me so long. No one listens to me. Why am I feeling so badly? Because what I'm saying makes sense. Why doesn't anyone listen to me? They listen to me, they shake their heads, they agree, then they go home and keep doing the same old, same old. So how have I succeeded? I'm giving the patients the same stupid 7 and 3 treatment. I feel like a total failure.
Well, we have to be careful. We spoke about this on the side.
Yes, let's open to questions maybe.
Can I give you this little gift from Max Weber?
I would love that, please.
This is the last public presentation he gave before he died. The title is Politics as a Vocation. So where he uses the word politics, I'm going to say science as a vocation. Politics or science is a strong and slow boring of hard words. It takes both passion and perspective. Certainly all historical experience confirms the truth that man would not have attained the possible until time and again he had reached out for the impossible. But to do that, a man must be a leader, and not only a leader, but a hero as well, in a very sober sense of the word. And even those who are neither leaders nor heroes must arm themselves with that steadfastness of heart which can brave even the crumbling of all hopes. This is necessary right now, or else men will not be able to attain even that which is possible today. This is 1990. And this Dr. Sadway it's a snapshot of what you have been doing for the past 40 years. If you have not reached out to the impossible in 1984, you will not have achieved what you have actually, which is possible. And if those of us who are coming after her do not reach out for that which looks impossible, even that which he has achieved will go to, I don't want to say it, but waste. And we owe this to our elders, those who came before us, and we owe it to the generations that are coming after us. So thank you very much, and we are delighted, and we hope to see you again in the near future.
Thank you. And I always like to end with poetry. Emily Dickinson, so beautiful. Faith is a fine invention. What a line. Faith is a fine invention for gentlemen when gentlemen can see. But microscopes are prudent in an emergency. Thank you so much for your attention and listening to this program. I'm very grateful. You were a great interlocutor. Thank you for the very thoughtful and thought-provoking questions you asked.
थोड़ी सी जसारत कर दूं, थोड़ी सी पोएट्री मेरी तरफ से.
इरशाद.
Obviously, मेरी पोएट्री तो नहीं है. ऐसा ये है कि whether we are citizens, whether we're academics, whether we are bureaucrats, we hear this again and again. There is no alternative. Tina. There is no alternative. These institutions are here. There's nothing you can do to think of something different. तो अल्लामा इकबाल ने एक नज़म है उनकी ये. The title, it's not well known. The title is Sufi Se, to the Sufi, he's speaking to the Sufi. But I would say this also applies to the scientist and the bureaucrat and Sufi Se. तेरी निगाह में है मोजज़ात की दुनिया, मेरी निगाह में है हादसात की दुनिया. तख़य्युलात की दुनिया अजीब है, लेकिन अजीबतर है हयात व ममात की दुनिया. अजब नहीं कि बदलते उसे निगाह तेरी, बुला रही है तुझे मुमकिनात की दुनिया. And we are blessed to be in Laos. it points towards a possibilities. It points to, it gives us the room to imagine possibilities which cannot be imagined or pursued at Columbia University. I say this as a cool sociologist, as a cool-headed sociologist. We do have that opportunity. And we have resources like this that can help us to nurture this mumkinat, that there are alternatives, but we have to gather together the courage, just like she did as an individual, without any support system around her. I know, because I went to the United States, or my family went to the United States in 1976. I know what it was like back then. I grew up there also. So with resources like this and an environment like this, we can do wonders. But it will take the coming together of art, the hard sciences, and the social sciences, and the artists, the scientists, the social scientists, the humanists. So thank you very much.
I wish we could go on for more time, but the clock tells us that it's time to wrap up. But we still have a few minutes to open the floor for questions and answers, and we can start from here.
Dr. Sama, thank you very much for this wonderful discussion which you have. I have a comment and a question also. First of all, the question. As an alternative to this slash poison and radiation, how about this cyber knife thing? We are listening a lot now that this cyber knife, it doesn't do any of those slash poison or radiation, but still it cures the cancer. So I would first like to get an answer on that question, please.
No, you heard wrong. I mean, cyber knife is a different way of doing surgery. So it is removing things and slashing, and we should have better solutions for it.
Okay, thank you. Comment, I mean, it's related to, it's often said that half of the patient suffering is gone when a doctor is a compassionate person like you are with your patients. But I mean, it reminds me of a share from John Elia who says, मैं भी बहुत अजीब हूँ, इतना अजीब हूँ कि बस खुद को तबाह कर लिया और मलाल भी नहीं.
Yeah.
So how would you say, if any person is in that kind of situation, how to get him out of this situation? Thank you.
I'm so sorry, I don't have an easy formula to give you. That go and say this to them or read that poetry or that book. That's the kind of complexity that humans pose to us. And I think it may take family for one person and a good doctor for another, or simply medication for a third, or watching a good YouTube video for a fourth. I don't know. It could be a combination of all those things. I don't think I'm equipped to answer how to deal with such a complex issue. Okay?
Ji.
Thank you very much for a very thought-provoking talk. The question I have is, we talk about the first cell. What is the first cell? Is it when cancer is detected in the first cell, or is it going before that as well?
A wonderful question. Thank you for asking that. Because we call it the first cell stage of cancer. So stage 1 is not the same as first cell stage. As I said, hadsa ekdam nahi hota. The ground was being prepared for the first cell to appear. What was preparing that ground? Those factors are important to look at. My own hypothesis is that cancer is such a well orchestrated response, of cellular response, that it can't be due to some random event. In fact, the thing that is most carcinogenic to Do you know what it is? What causes cancer the most? Aging. It is a disease of aging. If there are 2 million new cases diagnosed in America every year with cancer, in adults, 15,000 appear in children. There's a big difference 2 million versus 15,000. So it is a disease of the elderly. What is it about aging that is making us susceptible for this? Well, the most obvious thing is a chronic inflammatory state sets up in the body as our organs are becoming decrepit. And that chronic phase of inflammation, which is irritating gas, which is irritating cells in the pancreas, in the stomach, in the lungs, these very cells then, these very organs are being repaired under conditions of stressful chronic inflammation. And the cells are getting the signal fight or flight. Either develop a strategy to survive under this stressful condition or you're going to die. And one of the strategies then goes awry and the cell becomes immortalized in trying to survive that condition. So you're absolutely right that before the appearance of even the first cell, there is that stress we should be looking for. And my whole life has been devoted to saying that we can use blood as a window into all kinds of diseases because in the end, stress markers are shed into the blood. Why aren't we looking for that? We should be taking blood from every patient, every cancer patient, and using the latest omics technologies, the latest cellular technologies, the latest technologies for in finding pieces of RNA, DNA, proteins in the blood, and analyzing them to show that this is what is associated with cancer and this is not. So, first cell means really the first cell stage of cancer, the inception stage. And I think your question is spot on.
Excellent. Thank you very much. It was really fascinating to listen to all of that. So, one aspect is what you were saying is that go and find the first cell or before and then take care or cure that. Other is that I, as a kind of layman, because I have nothing to do with the medicine, I see that we not live in a lot more exposed to a lot more toxins, compounds, maybe plastics, maybe many other things in our food and the pesticides and all those items. And so I want to know what is your take on that because one view is, and I kind of believe in that view, and for no reason, it was just reading the newspapers, that because we are more exposed to all these compounds and toxins and all that, that's why the cancer numbers have really increased in the past few decades. And we all need to really, go back to the basics, start using the spoons, wooden spoons, and plastic should be out of our home and have ceramic cups and whatnot, and don't use the microwave and so forth. So your research or maybe some interdisciplinary work you are doing, is there a take on that, and is there a takeaway for us that maybe the lifestyle changes which we need to make early on in our life to reduce the chances of that? Please, if you could comment on that.
No, those things, I think you are very correct in saying that all these things matter. It's bad if you smoke. You are going to have a higher chance of getting lung cancer, but not everyone who smokes will get it. They may get some other disease. Yes, exposure to toxins is bad. But the problem is that someone can lead the most pristine lifestyle and yet get cancer. So it can't be explained away just by any one thing. It's not a generic susceptibility alone. It's not just exposure alone. It's something else going on. And we don't have time to try and unravel that and try to understand every microscopic detail of this. All we can do is just try to find changes that are associated early and try to mitigate those in time so that they don't progress. That's what I'm saying. Otherwise, if we may understand all of these possibilities, but it will take 1,000 years, and we can't afford that. Too many people are dying every year of cancer. So I think that obvious common sense things you have to do. You have to take care of lifestyle. You have to have a good diet. You need to exercise every day. You need to take your vitamins, etc., etc. But also you need to get screening done for cancer because you're not sure. Still, you're not sure. And by the way, the problem is that younger people are getting cancer. Every cancer center in New York right now is opening clinics for individuals under 45 who are getting cancer. And GI cancer, especially colorectal, has increased dramatically in the last 14 years. Nobody can explain why. And there are now epidemiologic studies coming out saying climate change has something to do with it. So these are again complicated issues. We don't have the wherewithal to resolve these in a quick, in an immediate future. So the best we can do right now is try and prevent.
Uh, we have time to only go for two more questions, and those two questions can be asked together, one after the other, and Dr. Azra Raza can respond then.
So it's so heartening to hear you, Professor Azra. So listening to you in last few days, I realized we are not doing things that bad here. In particularly the classes I teach. I teach developmental biology, and it's difficult to talk philosophy in front of Basit, but I try to treat it that one. So when I teach developmental biology, on day one, I tell my students you have to watch Ashfaq Ahmed ka ek drama hai, Man Chalega Sauda. So that's part of the developmental biology course we teach. And try to go away from hard science so that they learn about themselves, what they are. Coming to your first cell and having this dev bio background, the first cell when I saw, I said, wow, what a title. Because for me, the first cell is the fertilized egg. So one day I was in my mother's womb and, the 46 chromosomes came together. And that was the first cell which defines what I'm going to be in next 9 months, because the environment in which my mother had that pregnancy, that is going to define pretty much my long-term health and my mental health and whatever. What are your thoughts about, that first cell may have something predetermined? And I'm not talking about genetic predisposition. I'm not talking about epigenetics. I'm talking about the environment, the first 9 months in which that first cell multiplied, made a baby like me, then that grew. And somehow there it's written that, at time point X, Tariq will develop cancer. How we will catch that first cell?
I think that is perfectly possible that you're born with not a genetic susceptibility but a congenital or an inherited susceptibility from the microenvironment in which the fetus developed. And by the way, in the 1980s and 90s, there was a lot of research which claimed that homosexuality is because of not any genetic reason, because they could never find any genetic kind of susceptibility for it, but the mother's womb. If mother had an overdrive particular hormonal issue, then that could be associated with the child becoming homosexual. None of those have panned out actually. But to answer your question, we don't know what would happen, what gives this susceptibility. But I can tell you one thing which I find very interesting. We can find pieces of DNA shed by cancer cells that are floating into the blood. and these can be detected. So it started with maternal fetal thing. Um, I got pregnant when I was 39, and that was old. So I had to have a procedure called amniocentesis. A very thick needle had to be inserted, and some amniotic fluid was withdrawn. And they looked at the cells of the fetus to make sure there were no developmental abnormalities and the genetics were okay, etc. Now, as they were doing this kind, somebody had an idea that, oh, the fetus must be shedding cells or DNA into the maternal blood. Maybe we could get those pieces of fetal DNA from maternal blood. And so they started finding that. And this cell free CF fetal, cell free fetal CFF DNA has now replaced amniocentesis. We can 2 drops of blood from a mother can tell us about the health of the baby that she's carrying. And this is to me a dramatic thing because when we used to insert those needles blindly, sometimes we cause damage to the fetus. Well, it occurred to some smart person that hey, then cancer cells must be shedding DNA also. Let's look for cell-free DNA that has mutations in it which are associated with the cancer. And sure enough, they started finding that cell-free DNA having mutations of cancer. The problem was now, let's say they took my blood and they found a piece of DNA that has a mutation. But that mutation could be associated with lung cancer, pancreatic cancer, ovarian cancer. They don't know the tissue of origin. So they started looking at the methylation profile because that is very specific for an organ. It's like a zip code. Liver has a certain methylation, pancreas have another. And then they could tell the tissue of origin. Not only is this little piece of DNA indicating that there is cancer somewhere, it is coming from the pancreas. You go and scan the pancreas, there is no cancer by the scanning measure. But now you know you have to be vigilant. You scan every month and suddenly you find the tumor. So you have detected it way before, right? Before even stage 1. What I'm trying to tell you, what fascinates me is that I'm just full disclosure on the board of the company that does it. So Grail is a company that started doing this cell-free DNA for cancer detection, and they use AI. So they train for machine learning their AI platform by feeding it information on millions and millions and billions of pieces of DNA. And now, do you know what has happened? The platform doesn't have to look. AI is so powerful that after being trained, this machine learning has led to a point where they can find a piece of DNA, it has no mutation at all. But just based on a particular methylation profile, AI can tell you if this little piece of DNA coming from a cancer cell or a normal cell. They've stopped looking completely at mutated DNA. So I'm on the board of that company, and I said to them that this is a dramatic finding because a cell has a long piece of DNA. It can spread to a meter long, right? Several a meter long and wrapped up. You are finding just a tiny piece of that meter of DNA from a single cell, and yet you are able to say that this is coming from cancer. So I said this methylation profile must be telling us something. You know what the answer was, Tarek? Yes, but we are not interested in biology. We are a company, so we have to just go for the market share of this test. This is the contradiction that I'm talking about. This separation that doesn't allow. So academia that could do the research doesn't have access to this technology. Those who have access to this technology are sitting in their silos and protecting and monopolizing their knowledge. This is the kind of thing that can be, and it's costing lives. That's the problem. It's costing lives. But I'm very, very optimistic. I'm not someone easily silenced, so I keep going on and on and on at them and harassing them about working. So they started working with us, looking at the tissue repository and the methylation signals moving backwards. And do you know already, we have published this work already. I'm doing bone marrow biopsies using a very long needle with an electrical drill that I still do with my own hands, 8 to 10 patients a week sometimes. In a day I have to perform. Very procedure heavy clinic I have because everybody has leukemia, so everybody needs bone marrow, whether they are being treated with this, what's the result, we have to look at the marrow. It is not only a painful procedure, more than pain, it's the anticipation of that procedure and that big needle that drives patients crazy. I tell them smoke some weed before coming in, please, because you're so anxious, not gonna hurt, but you're driving yourself nuts with that anxiety. But now we are finding that from few drops of blood using this methylation platform, we are getting a better information about prognosis and all kinds of things than bone marrow aspirate, biopsy, flow cytometry, cytogenetic, genetic profiling, all combined together. So I'm saying that this new technology will replace all of those horrible procedures by just getting a couple of drops of blood, not even drawing in a syringe, but just a pinprick. Better still, why not insert a device inside that continuously monitors the human body 24/7 for appearances of any disease caused perturbations and sends a signal to your cloud, which then gets translated on your cell phone simply to say, hey, don't eat an extra amount of dessert today because your blood sugar is going up. That's the kind of thing we are aiming for, and it is around the corner. It is not up high in the sky. These kinds of treating the human body as a machine, monitoring it 24/7, and looking at all the petabytes of data, analyzing it through AI platforms is going to make this happen. I'm very excited about it, and this is the kind of young people who are present in this room. I urge you to keep reading, keep educating yourself. You will get the idea. Sitting here, you can do a lot in this area. And sitting here in Lahore, think about the strengths that you have that we don't have in the US. What could they be? How could you contribute towards just collection of knowledge? It doesn't have to be monetized. It doesn't have to be that you replicate everything being done in the labs in America, in the labs here. You can do different things here. Use your resources more efficiently. Because I tell you, the amount of superb IQ and star mental power that these people, young people in this room have today, completely overwhelming and daunting. And have teachers like Sherpa Mirza sitting here and Tariq sitting here and Basit Koshal. I can't imagine better teachers than these individuals, and they are investing their blood, sweat, and tears to make you think differently, to make you into realizing what you can do to improve humanity. Thank you. Your only goal in life should be only one goal in life. That is how to reduce human suffering. What can you do about it? And one way is to add to the knowledge, the collective knowledge of humanity. How can you add to it? Sitting here, you have a laptop computer. That is so powerful. Start imagining things. Start imagining and visualizing big things and doing it and sticking with it. That's the key. You don't give up. You fall, you rise. You fall, you rise. And you will get there.
She has gotten there. This is not theory. This is not poetry. This is not philosophy. This is a lived life.
Thank you.
And after this first visit, we must keep getting her at least twice a year. With that, thank you very much for being here today. This was a fascinating session. We all learned a lot, and we as Dr. Azra Raza has asked us to, we continue to do whatever we can in our own individual capacities of improving ourselves and making this world a better place to live for others. Thank you very much. Thank you.